All right, my man, the House and Senate both gavel in at 4 o'clock this afternoon, and we are getting some gray hairs on this session, being that this is the 8th day in the month of March, probably, another 3 weeks?
Probably.
And then we wrap it up. So one of the biggest things that we've got to take care of is Medicaid, and I know you're with the Hospital Association, and I know the hospitals would love to have an expansion, and I know it doesn't look likely. But I know there's a push out there, so I'll let you make your spiel and tell it. Well, where is the bill now, or the bills,
sure,
for that matter?
Really, Paul, what we're watching now are two bills, the two Medicaid tech bills, and the Senate, of course, passed Senate Bill 2799. It came over to the House. The House did a strike all on that bill, took everything out, replaced it with the original House language of House Bill 1008, and then they also added from House Bill 1013 the Medicaid Commission language. They put that back in the bill as well. It went over to the Senate but died in the Senate, so they put it back in this bill. So interesting change.
What is that? What's that language? What are we talking about?
You know, it actually removes Medicaid from under the governor's office and sets it back up under a commission like it used to.
That's still a live possibility.
It has been breathed life back into. So we'll see. That's interesting.
What's your view as far as the association on that?
Paul, it doesn't matter to us. It worked before.
It's got to matter to somebody.
Well,
is it a power struggle, or is it an efficiency move, or?
I think there is some. I think there's an awful lot of money that's tied up in Medicaid. I mean, it's the largest budget item we have, and to have additional eyes on it, additional processes to look and see how it's working. That's probably not a bad idea, but we're not taking a stand on that.
If that happens, how long is it going to take? You got to form a board. You're talking about that.
That's correct. Right? That's correct. It'd work like the health department. And
so is that going to put a delay in implementing or processing all of the Medicaid stuff that you do because of that? You have to start over.
No, I wouldn't think so. I think whatever's passed this year would move forward, and then the implementation of that board would come in as of July 1. Typically, how that would work. So no big issue there.
Have you been able to kind of, through the lobbyist and all of your connections out there, sniff the winds and see how that's going? Is there enough support for that to give it merit?
It was strongly supported in the House. Evidently, not so much in the Senate if it died the first time. So now tying it into the tech bill, is that going to make a difference?
Yeah.
It's all going to come out in conference. We're going to be in conference to talk about all these things.
What are give me the dates here. I mean, as far as deadlines are concerned, is that 2 weeks away, or how long is that one?
Yeah, well, let's see. Original bills are this Wednesday maybe, March 10th. Deadline for original bill, floor action on original bill. So they would have to take action and call conference.
So that Medicaid bill's got to come out by day after tomorrow?
I believe that's right. As far as it's off the floor.
Not next week, but this week. You're talking about this Wednesday.
Yeah, I think that's right.
Jeez.
We'll have to check that. But it shouldn't be a big deal. They're just moving them back and forth now.
Yeah.
The Senate has already moved it, and it's over there. It's just come up on the calendar and move it forward. They're both going to go to conference.
You mentioned to me that there were a lot of churches in the state who also wanted the House and Senate to take a look at the possibility of expanding the Medicaid rolls. I'm confused because sometimes we hear that the government's going to pay for it all, no problem, but this is what it's going to cost us, and this is without any changes in Washington, D.C., and I have heard up to $200 to $400 million additional.
Mm-hmm. If you look at the Biden plan, that's kind of this boosting of things going along, it adds a 5% to our FMAP for 2 years. So what it would do is it would actually pay additional money for those individuals that are non-expansion or people that are outside of the current Medicaid program. That wouldn't even count. This would come in, and that's an estimation. There's about $300 million that would come to the state. Now that's not counting what would come from the elimination of the uncompensated care side. Which is what we've talked about, and what we keep hearing the state can't afford it, and all these things. And we've said repeatedly, hospitals have stepped up and said, "Look, we will cover the state match. There'll be no cost. It will be an increase." So you're looking now at the potential of another $200 million coming from a plan that will eliminate at least half of the uncompensated care in the state of Mississippi, in addition to the new incentives that the federal government's putting in place to increase the FMAP by 5%. Yep. So you're looking at almost $500 million straight to the state treasury.
So the hospitals would have both, but they'd still retain uncompensated care to be able to write that off.
Well,
you said about half,
but you'd still be paid for most of it, and that's the big thing. The writing off doesn't help us a whole lot, but actually not any anymore. But if you're able to pick up 40 to 50% of $600 million a year that our hospitals have in cost. Now, you and I have talked about hospital bills and how crazy hospital bills are.
Yeah.
These are not hospital bill charges. These are actual costs of providing care for the population.
And this is with all of the money that came in as far as COVID's concerned, it really hasn't changed anything. As a matter of fact, I think the last time you were here, you said the hospitals are deeper in death after COVID than before.
The uncompensated care has gone up.
Yeah.
Matter of fact, I had some discussions with some hospitals that said it's almost doubled in their facilities. And that's just because you've got to take care of those patients.
How's it changed? How's COVID changed the entire landscape as far as across the state and hospitals?
Oh, wow. There has been good things and bad things. We've been able to identify a lot of things that need to be done differently. How do we become more efficient? How do we take care of a more infectious patient? Just thinking of innovative things, Paul. I'll just give you an example of this, and it's very simple. But IV tubing. If you're looking at a patient that you're having to go in and constantly check IVs, if you extend the tubing to the door, then you eliminate the need for protective coverings, and you're able to save the personal protective equipment. So we had hospitals that looked at extending equipment to reach a patient so they didn't have to go all the way to the patient to get exposed. So little things like that, monitoring different ways, actually taking care of patients in different settings that we've had to go in and set up ICU-type areas that were not originally ICU areas. They've had to get very innovative.
Especially for the elderly or the nursing home patients and people like that.
Oh, absolutely. Absolutely.
But and I don't think most of us can comprehend this. Tim Moore is my guest this morning. That in the early days of this, we really didn't know how bad it was.
We did not.
And I mean, if somebody just walked into the room, they had to shed their PPE and
start all over.
And sometimes they do that.
Multiple
times a day.
Absolutely, and multiple
people. Yeah.
So you got it. You understand.
No wonder we had a shortage.
Absolutely, and nobody had planned for anything like that. Yeah. We have been going down the road for years to move our population that we care for to outpatient.
Yeah.
Not have inpatients anymore, and we've done a really good job doing that because of course that's how you get paid. You don't get paid on the other side. So this really caught everybody in a difficult situation because you were not really prepared for it.
There's some things that are just transformative. We talk about that. We talk about telemedicine. We understand that. Broadband, we understand that. We talk about water lines underneath the ground that have been there for ages and ages. Nobody's paying attention to it. Absolutely. Things change. I think you said, and I have heard other people on here saying that the entire structure of hospitals, clinic care, rural, because of a multitude of things, from telemedicine to the automobile, everything else, the cost factor, CONs, everything, that we needed to retool and look at what today's hospital going forward, 2021 and beyond, what a hospital should look like.
Absolutely.
In tomorrow's community, whether it's in Benoit or Bay Springs.
Absolutely.
You want to paint a picture of that when we come back?
I'd love to.
Quick shot here. Some patients, and medically chosen here, some patients diagnosed with COVID-19 are experiencing, we've heard about this before, odd symptoms, a rash-like inflammation of the toes. Have you heard this?
Not just the toes, but yeah. Okay,
it's called COVID toes. Perez, didn't we talk about this once?
I believe we did.
Not much is known about the infection and why it happens, according to Dawn Davis, a dermatologist. Dawn Davis, the dermatologist. Good. Mayo Clinic. Way down. Anyway, COVID toes mimic a well-known ailment called pernio, skin sores or bumps that appear after exposure to cold. Symptoms include redness, purple discoloration, and papular spots of hemorrhage. I hope you're not eating this morning as far as breakfast is concerned, which the blood leaks into the surrounding tissue.
Oh, God, stop.
It can be itchy and burn. The ailment, which occurs in both adults and children, tend to last weeks and can be painful, sometimes itchy, oftentimes painful. To Dr. Amy Powler, these are individuals who often, without any other sign of viral infection, it's common. It is not known how common COVID toes are, but if you want to text me and let me know, it's especially strange about COVID. What is especially strange is that it often occurs weeks after the initial COVID-19 exposure. Have you heard anybody with that?
I have not heard of anybody that had COVID toes. We've actually started seeing some folks that had COVID initially that are having reoccurrences. They're having COVID again.
No.
Yes. So, I mean, and I say that just that, look, we still got to be careful. Whether we've got a mask mandate or not, we need to encourage everybody to continue to wear your mask, social distance, and do the right things.
I agree with you. I mean, I had some tooling around to get prepared for the smoking operation, and so I went to several different stores and just tooling around doing some things. Anyway, I wore the mask in every place that I went, and then I forgot it, left it in the truck. On one of them, I'm walking in, I felt like
I'm missing something.
All of a sudden, you just notice on aisle 40 that you're there naked with no mask, and you're thinking, "Oh my God, where's the next Karen going to be coming up at you?" But it worked out, and I got out rather quickly. So, all right, we were talking about the before COVID toes, the hospital of the future in the state of Mississippi. I know that's not an easy thing to do, but it needs to be something as far as transitioning to the future. Your thoughts on that?
Paul, I think it is a big change. It's a big transition. Now, we did see from a pandemic that there are issues that we need to be prepared for. So, at one point in time, we thought, well, we just need to get rid of the inpatient beds. We're not going to need them again. Well, we got proved wrong on that because we used all of them. But the actual treatment of patients is going to be done more so on an outpatient basis. It's going to be done through telehealth. It's going to be done by different skill levels of individuals. And, we've got to figure out how to put all of this together to form an even better system than we currently have. We've got the best healthcare system in the world. And we've definitely proven that by things that we've been able to accomplish. But we've got to figure out how do we continue to do more and more with less. We've all said that time and time again, we've got to do more with less. Well, this is definitely a case where we've got to do that. The funding is not going to get higher and higher, but in order to take care of the patients that we have to, we've got to figure out how to stabilize the funding sources, and then we've got to figure out how to be more efficient in doing it. So you're going to see in small areas, I truly believe, you will see more technology but think about that, Paul. Right now, we have difficulty doing that because all the state doesn't have enough broadband to carry it.
Yep.
So, but we're working on that. We've got opportunities, and we're moving forward to fix that problem.
So, number one, there's no way for us to constantly be in that bricks and mortar structure
Absolutely
of supporting a pandemic on a year-to-year-to-year basis when it doesn't happen 10, 15, or 100 years. You can't do that.
You just can't do it. There's no financial
whether it's
way.
mobile hospitals or something like that, that's got to be part of the equation. But the other part of this is nobody wants to talk about changing the structure. We can understand the bricks and mortar part of this.
Right.
Are going to be transformed and usually regenerate into different things over the years. But that relationship between the insurance company and the hospital and billing and everything else, if that doesn't change, and it's got to change.
It has to. It's got to change. And we're trying to work on that. And trying to get, and of course, Hospital Association has been very involved in a health information network. And we've got almost all the hospitals now are signed up. We'll be able to pull data from all the hospitals and be able to really look at more data to be able to drive better outcomes, and then also be able to determine outliers and focus on those. I say all that because that's exactly what our insurance companies want to have happen. I mean, all of our insurance companies are there certainly to generate revenue for their side, so that means you give less revenue to providers. Well, we got to figure out how do you make that work for both sides.
Do you guys take an issue or take a stand as far as the nurse practitioner bill that's no longer alive?
Paul, we've been consistent in our message. We strongly support nurse practitioners to work within the full scope of their practice, but we do strongly believe in a physician collaboration. And that's just where we are. We've been that way. We went back to our membership this year to verify that again, and they all came back and said, look, we got to support the same mission. We're not changing it now. Nothing has really changed, so we're not going to change.
The larger hospitals in the state of Mississippi, are they financially healthy?
Yes, for the most part, I would say that our larger tertiary facilities are financially strong. Here's something that would change that real quickly is if we lose a lot of the small ones. If you start bombarding our larger facilities with ER patients and with more uncompensated care, then they're going to have a problem too. It just works that way.
Where do you see telemedicine going as far as the hospitals are concerned too, though?
I think it will get even broader. I think you're going to see more of our small rural hospitals, particularly those that are affiliated with those large hospitals that you're talking about. They'll be tied in together. They'll be using the medical staffs on in their facilities. And I think the opportunities for telehealth, telemedicine, all the information that can be gathered from that type technology, it's endless. I mean, we may go back to the Star Trek days, and Bones may come over and scan us and say, tell us what's wrong.
Well, I think we're already there when you start looking at what can be done now. I mean, just take a look at what the watch can do right now.
Yeah,
it's just absolutely amazing.
Yep.
The other part of this is that when you look at the insurance companies that we have in the state of Mississippi, is that need to change in the future? Well, one of the things that we tried to do for so long, at least some of the conservatives, was to open it up across state lines and wherever, just like your car insurance. And I don't understand why we can't do that. It doesn't make sense to me. If I want to buy a health policy from Minnesota, wherever they happen to be, I can understand getting licensed in the state of Mississippi, but as long as they're a credible organization with a good rating, why couldn't you do it?
And going to pay the claims.
Is that just politics?
I think it has to be. And of course, you've got a lot of everybody's for competition until it's competing with them.
Yes.
So that's an issue, and I think that's part of the reason.
Speaking of which, I'm sure that means that you're all for CON now, the certificate of need, and any legislation to do away with that.
You just had to slip that in, didn't you? That's in a free market, Paul. Healthcare is not a free market.
Yeah. Oh, is that right? It's not a free market.
It is not a free market.
It's a socialist market?
No, but you could almost think of that. If you look at where our hospitals are, 65-70% of the payments hospitals receive are government funded. Mm-hmm. We're not far from a socialist health care program.
All right. Any other?
We'll do that one another day, huh?
Any other bills out there that you guys are watching?
No, not really, Paul. We're always looking from a defensive standpoint as to what's coming out here, but the tech bill is the big one. We certainly hope that maybe some miracles could happen in conference and there'd be some change of hearts, and let's look at what we can do for the working poor of the state of Mississippi.
Give me Tim Moore's my guest. Tim, give me some numbers. How many people do we have on Medicaid in the state of Mississippi?
Oh, is it about 720,000?
I think it is. It's around 700, maybe more than that now.
Last time I looked at it, it was somewhere around.
Let's say a little over 725,000 Mississippians. This is not children, or is this complete?
That's all. That would include children.
725,000, about what? 2.9 million people.
About right.
The expansion would raise that up another, what, 400,000, 300 to 400,000 people?
It would go, and the numbers vary there. We usually say around 200,000. The numbers go from 158,000 to 300,000, depending on the study you look at. But we kind of hit a mid mark there of about 200,000.